right, good evening. My name is Aaron Millstone. Thank you for joining us tonight for our first virtual SHEA Epi competition. It looks like it's about 6:02, so I think we'll go ahead and get started. Thanks so much for joining us tonight. I want to start by thanking our reviewers who completed a rigorous review process and pared the competition down to our top 3 proposals tonight. I suggested that we do this competition Wipeout style. For those of you who've seen the reality TV show Wipeout, I thought it'd be fun to see the contestants run across the big red balls to see who could win. But due to COVID restrictions, I was overruled. So here we are, we're gonna do a virtual evening, and I hope you all enjoy it equally. And thanks to our panelists and our contestants tonight. So what is the schedule? We've asked the contestants to each give a 2-minute overview of their project in case you weren't able to watch their video presentation ahead of time. After the overview, one of our panelists will spend about 15 minutes asking each candidate questions. Then the next contestant will go. And yes, we are referring to them as contestants to keep this more like a game show. The order was selected at random. We are not suggesting that the first contestant will get first place, but we'll see. Throughout the presentations, please add questions either into the Q&A or into the chat. I will be monitoring those as well as the other panelists, because after we've gone through the first round, we're gonna have a second round where we'll be asking follow-up questions of each candidate that are coming in, the questions that are coming in from the audience. So we will encourage you along the way to keep putting your questions about the proposals into either the Q&A or the chat. Our virtual judges are watching carefully to decide which contestant will win the competition and walk away with $1 million, just kidding, $20,000 to support their research proposal. We have 3 great candidates, so thanks for joining and let's get going. Our first candidate will be interviewed by Dr. Sarah Krein from the University of Michigan and the VA Ann Arbor Center for Clinical Management Research. Sarah will be talking with Salma Abbas about her proposal, Diagnostic Stewardship of Multiplex Molecular Panel Tests to Improve Antibiotic Use. Dr. Abbas is joining us from Pakistan. She is drinking coffee because it's 3:30 in the morning there. So we're very happy that she's with us, and I turn it over to Sarah to take it away.
Great, thanks, Aaron. And also thank you, Salma, for joining us at such an early hour. So I really appreciate your being here today. So to start out, my first question for you is I'm really interested in hearing a little bit more about the backstory for this project and the motivation for proposing the study. So actually, let me give you, wait a second, you do your 2-minute spiel first, then I will ask you that question.
Thank you so much. Hi, everyone. I'm Salma Abbas. I'm an infectious diseases consultant at Shaukat Khanum Memorial Cancer Hospital and Research Center in Pakistan. And I'm honored to be a finalist in this competition and to be sharing my work with you. So I'm going to give you a brief intro of my project. It's titled Using Carbapenem-Resistant Enterobacteriaceae Colonization Status to Guide Empiric Antibiotics for Febrile Neutropenia. So febrile neutropenia, as we all know, is associated with significant morbidity and mortality. And this highlights the importance of timely and appropriate management of this condition. Currently, the Infectious Diseases Society of America recommends initiation of an anti-pseudomonal antimicrobial such as pip/taz, meropenem, or ceftazidime as the initial empiric therapy, but these guidelines do not take into account the global variation in CRE burden. And it's important to note that these must be modified according to the local epidemiology. And this is important because colonization with carbapenem-resistant Enterobacteriaceae, that I will be referring to as CRE, may result in infections in patients with febrile neutropenia. Infections with multi-drug-resistant organisms such as CRE are associated with higher morbidity and mortality. The knowledge of exact mechanism of carbapenem resistance can help guide therapy. In regions such as Southeast Asia, where New Delhi metallo-beta-lactamases, that I will refer to as NTMs, and oxycylinase types such as OXA48-like carbapenemases are the predominant ones, the administration of a polymyxin or aminoglycoside in combination with the carbapenem as empiric therapy for febrile neutropenia may improve clinical outcomes among CRE colonized patients. Through my study, I aim to identify rectal carriers of CRE among patients with heme malignancies undergoing chemotherapy or hematologic stem cell transplant, patients with evidence of CRE colonization will receive a carbapenem and colistin as the initial antibiotic therapy for febrile neutropenia if they have a normal baseline renal function. We hypothesized that empiric antibiotics guided by CRE colonization status will improve clinical outcomes among patients with febrile neutropenia in a region with a high burden of CRE infections and colonization. The null hypothesis for my study is that compared to a historical cohort, there would be no difference in the 30-day all-cause mortality with the implementation of routine CRE surveillance testing and modification of empiric therapy for CRE colonized patients with febrile neutropenia. This study will generate critical pilot data that can be a stepping stone for future projects such as randomized trials and can also impact clinical guidelines. Thank you.
Great, thank you so much for that overview. And since I jumped the gun, now the question is if you could tell us a little bit more about sort of what your motivation was for proposing this particular study.
Yeah, so I did my internal medicine and infectious diseases training in the US, where the disease, the infection, the epidemiology was completely different. And we were always worried about MRSA and VRE. We would get 1 or 2 CRE infections per year, and that would be like an alarm set off, you know. So when I moved to Pakistan, I saw the contrasting epidemiology, and we see a lot, you see a very high burden of CRE infections. And if I just talk about bacteremias, so of all our bacteremias, 20% or so are caused by CRE. So, and you know, off the bat, when we get our febrile neutropenia patients admitted to the hospital, we start them on piptaz or a carbapenem. And a lot of times we run into situations where they land into ICU with septic shock, and we get their culture results 1 or 2 days later. And that's when, you know, in most cases, their antibiotic therapy is modified. So I believe that if we are able to identify CRE colonized patients, and using the logic that CRE colonized patients will develop infections with CRE, this project is going to help impact morbidity and mortality associated with febrile neutropenia patients in our setting.
Great, thank you for that. So the second question is a little bit more about how you're going to, how the patients are going to be treated, and this is both clinically, but I guess from my perspective, almost more analytically, if they have more than 1 hospitalization for febrile neutropenia during your study period.
Yeah, so since we are only going to check them for colonization once at the beginning of their chemotherapy, and since we know that patients can remain colonized with CRE for up to 6 months, which is our study period, we will treat them the same way if they are CRE colonized, which is with colistin combined with a carbapenem, if they have, even if they have repeated admissions with febrile neutropenia.
Great, thank you. And then just kind of a follow-up to that, in the analysis part, are you going to include all of their hospitalizations or just one of their hospitalizations, or how do you plan to deal with that? So
every hospitalization will be included because we are talking about different episodes of febrile neutropenia and the mortality associated with those episodes. Because someone who comes in with a CRE infection once can come with a CRE infection again when they're neutropenic. So for that reason.
Great, thank you. And then another question, since I'm very interested in the research aspects of this, obviously, given my background, I'm wondering how you're going to collect the data for your patients in this particular study, because you have 2 groups. And so is there a methodology? Are you going to use electronic data, or what was your data sources, and how do you propose?
Yes, so our health record is completely electronic. And pulling data is not going to be an issue, both for our retrospective and the prospective arms of our study. So for the retrospective one, we're going to have our IT department help pull all the data with regards to the patients with, and just to make sure that we don't miss any of these by applying filters, we will go by the patients, because we have a list of all the patients with heme malignancies who are either started on chemotherapy or transplant. So we're going to start with that and look at their charts to determine who's eligible to be enrolled in the study. And for the prospective arm, similarly, we're going to use the same method, and we'll be working very closely with our heme-onc colleagues who are also going to be participating in this study with us. So obviously we're going to, have a meeting with them at the beginning of the study and share our methodology with them. So they will help us identify patients in the prospective arm. Once these patients come to the emergency room with febrile neutropenia, an electronic health record alert will be generated, and physicians in the ED will be alerted to these patients so that they are started on the appropriate therapy according to the study protocol.
Great, thank you. And then there was a question from the audience, which I guess I'll insert here, which is about the sample size. What you think your potential sample size will be for this project?
So with the COVID restrictions, over the last 6 months, we had about 99 patients in total, 50 of which were started on chemotherapy and 49 underwent hematologic stem cell transplants. Now we're thinking that we are going to have a higher number of patients just because of the re-expansion of services and also because travel restrictions have been eased for the most part. So we are shooting for 150 for the 6-month study period for the prospective arm.
Great, thank you. And just to follow up a little bit on that, so could you describe a little bit more the sites for this study that you're going to be recruiting patients from?
Yeah, so so I work at a healthcare system, and we have 2 hospitals, 2 dedicated cancer hospitals as part of this healthcare system. One is a 220-bed hospital, one is a 30-bed hospital. So the bigger one is where these patients are initially screened for treatment and started on treatment, and we determine if they're eligible for that treatment. So this is where patients will be enrolled, and regardless of which one of our hospitals they present at, they will be started on the same treatment if they are, because our electronic health record is integrated.
Great, thank you. So now another sort of more analysis focused question. How are you going to deal with the patients who are hospitalized for febrile neutropenia but don't consent to the rectal swab?
I'm sorry, who are hospitalized but
do not consent to the rectal swab, so you won't know their colonization status.
Definitely, because there's an intervention involved in our study. We definitely will be including only those patients, or we will only be collecting rectal swabs from patients who consent to participate in our study. But as you are aware that one of our in this prospective arm of our study, we have patients who are CRE colonized and those who are not CRE colonized. So they will still be a part of our study because we want to look at the mortality benefit if we are able to achieve that with modification of our policy, of our current guidelines according to CRE colonization status. So we will not include them, but if they don't consent, we will not collect rectal swabs.
Great, thank you. And then we're just curious about sort of the study team that you're going to be working with. In terms of, do you have people who are going to be working with you providing mentorship, or who else is going to be involved in this project?
Yes, definitely. I will start with my mentor. This is going to be Dr. Faisal Sultan. He's an infectious diseases physician with the 25-year experience in infectious diseases, public health, epidemiology, and infection control. Other members of our study team will include another one of my colleagues, also an infectious diseases consultant, Dr. An Raza, who is also an infection control person. Then obviously our microbiology lab is going to have a very important role. So Dr. Sumaya Nizam is going to be, she's a consultant microbiologist who will be participating from the microbiology lab. Hematology oncology consultant. So we're going to have Dr. Bushra Essen, who's one of our hematologists here at our hospital, be a part of our team. We also have Mr. Rehan Niazi, who is a pharmacist, who's an ID trained pharmacist, who will be a part of our study. So these are the team members, and we will need IT support. So they're going to help us with generating the EMR alerts. This is my study team.
Great, thank you. And then there was another question from the audience about quality control for the rectal swabs, and is there going to be a washing period for staff? Since you were just talking about the lab.
I'm sorry, can you say that again?
Sorry, so there was a question about whether there will be quality control for the rectal swabs in a wash-in period as far as they're being collected and then processed.
Yeah, so if I understand this question correctly, so we are actually using the CDC criteria or the CDC method that's been outlined for collecting CRE rectal swabs to detect for CRE colonization. So the first step is to collect the swabs. They will be directly transported to our microbiology lab, which is on site. And since this is not going to be the first time that we are checking someone for CRE or that we are using the gene expert system for determining the mechanism of CRE resistance, that's already been QC'd and quality checked, so it's up and running. We just haven't started doing that on a large scale. Once we have transported the samples to the microbiology lab, they will be plated on McConkey's agar with meropenem discs. And to ensure that that's not the sole method that we are relying on to detect CRE, we will then identify those that are consistent with CRE using MALDI. And as a third step, we will also perform a gene expert carba-R testing to determine the mechanism of resistance for carbapenemases.
Great, thank you. I think that answered a couple of the other questions that were popping up. So next, I was wondering if you could just, since you described this as a pilot study for larger studies, which certainly seems appropriate, I'm just wondering what sort of information or findings you're going to consider that would prompt you to decide that this warrants a larger study or would make you decide not to move forward with this approach.
Yeah, so this is obviously a small study. Because if I'm shooting for a sample size of 150, this is a small study, and even if I'm able to collect data or if I'm able to identify a similar number of patients from the retrospective arm, that would still take the total to up to 300. But that said, we know that heme malignancy patients, I mean, they're going to be a subset of the entire cancer patients at any hospital. So just to get a larger sample size, I would definitely move on to a larger study, such as a clinical trial, regardless of the test results. I mean, I hope that I'm able to see a mortality benefit because the hypothesis, makes sense based on our clinical experience and the data that is out there regarding the higher morbidity and mortality associated with CRE infections. The larger studies would entail including only CRE colonized patients. These will be multi-center studies. There are a few other cancer hospitals in the country that we will approach to include in our in further studies, including only CRE colonized patients. And among those, we will randomize 1:1 to patients who will be receiving colistin with combination with the carbapenem, and those who will be receiving standard of care, which is piptaz or ceftazidime or a carbapenem as initial empiric therapy for febrile neutropenia.
Great, thank you so much. Well, I think we're at our time, so I really appreciate your giving us a better understanding of how you're going to move this project forward and some of the challenges and things that you're facing, and we'll be able to work to develop a larger project. So I think we have everything we need for the moment, and I'm going to hand it back to you, Erin.
My pleasure. Thank you so much.
Wow, 15 minutes exactly. That was perfect. Thanks so much, Sarah and Selma. Great job. Thank you for your robust answers at 3:30 in the morning. Very impressive. Now we're going to move on to our next candidate and panelist. We have Dr. Matt Ziegler from Penn at the Perelman School of Medicine, who will be interviewing Mindy Sampson. Mindy's proposal is entitled A Comprehensive Analysis of SARS-CoV-2 Strains and Microbes in Healthcare Workers with COVID-19 Infection after SARS-CoV-2 mRNA Vaccination. Over to you, Matt.
Thank you, Erin. And I'm glad to welcome Dr. Sampson here. And I'll pass it over to you, Dr. Sampson, to give a brief introduction to your study proposal.
Thank you. So my name is Mindy Sampson. I'm an infectious disease physician and epidemiologist at Atrium Health in Charlotte, North Carolina. And the title of my project is a comprehensive analysis of SARS-CoV-2 strains and microbes in healthcare workers with COVID-19 infection after SARS-CoV-2 mRNA vaccination. And the goal of our project is to investigate COVID infections in individuals who have completed vaccination with one of the mRNA vaccines. And our hypothesis is that those individuals who have become infected after vaccination are more likely to be infected with a new variant. To investigate this question, we are going to use metatranscriptomic analysis to identify and both characterize these variants. By using this technique, we'll also be able to identify respiratory co-infections and microbial and host RNAs in the upper respiratory tract that may be associated with vaccine breakthrough infections. And our aim with choosing this method for looking with full metatranscriptomic analysis is that we're looking at more than just identifying the SARS-CoV-2 variants. We're also hoping to see the impact of the microbiome and host variation on infection after vaccination.
Great, thank you very much. To the first question, I was hoping that you could share a little bit more about how your experience as a hospital epidemiologist led you to the study of genomics and transcriptomics for this proposed project.
Thank you. That's a really good question, because this whole project came from what we're seeing every day, in the clinical and epidemiology world. Part of my role is to, throughout this pandemic, has been to be involved in our employees that have been infected with COVID, and looking at answering the questions that have come up that, that SHEA has helped us answer throughout the pandemic of when can these individuals go back to work? How long are they infectious? And then more recently, answering the question of what do we do after somebody is vaccinated and is experiencing symptoms and then have tested positive for COVID again? Do we treat these as true infection? And what's the clinical significance and the epidemiologic significance? So along with my other epidemiologists and physicians that I work with, this really stemmed from just trying to answer real world problems throughout this pandemic.
Great, certainly not the easiest job of the past year, but on to the next question to get into the weeds a little bit. I would like to know more about the correlation network analysis that you had planned for the study. Which clinical or outcome variables were you most interested in? And do you anticipate that those variables will vary sufficiently for your analysis within your subjects?
Yeah, so we're going to be looking at, I think one of the biggest questions is microbiome. So as you probably know, there's a lot of research going on into microbiome and how it affects both viral infections and particularly infections or vaccines as well. So I think understanding what pathogens could be present, or not pathogens, but just what is present in the microbiome is definitely a variable that we'll be looking at. And then also looking at what the gene expressions are of these of the pathogen or the microbes that are present as well. So I think those are two of the variables that we are hoping to truly look at, along with just understanding what variants are present. COVID variants are present.
If, to follow up on that question, particularly focused in on the microbiome, and there may be some differences in the microbiome from one subject to the next that you've enrolled. Roughly, how many subjects do you plan to have for your study, and is there a breakdown as to how many you expect will be in one group versus another group for your study?
Yeah, so as you probably saw in the proposal, this is definitely a pilot project, and we're going to be limited with looking at an estimate of about 10 individuals that we can enroll into this study. Unfortunately for the study, we already have identified at least 10 individuals that we will be able to have specimens and that we would be able to enroll into this study. I think, as we're continuing to learn about the variants and how the vaccine rollout is going, I think I anticipate that we'll continue to have more potential to enroll into the study and expand it into the future as well.
Good for your study potentially, but bad for us. So the next question for you, are there any predictors of vaccine protection that may not be captured by the microbiome or the transcriptome, particularly the transcriptome of the nasopharynx where you're getting your swabs? And if there are those variables that you can't account for, do you have any plans to incorporate them in the analysis?
Yeah, so and part of this we're looking at both, we are using and both and RNA and small RNA, and we're hoping that that is something that we can account for as well in our project, because there's been some data that potentially small RNA also affects gene expression of some of the microbes present. So that will be something that we're looking at in addition to just identification of which genomes or what is present within the microbiome.
Great. And next question for you. For this proposal, your primary emphasis has been to look at post-vaccine COVID-19 infection.
Mm-hmm.
How do you hypothesize that your findings, the microbiome and the transcriptome of the nasopharynx may differ in these patients or subjects compared to those who've been infected but haven't been vaccinated?
Yeah, so I think that is a really interesting question. So I think that currently we're starting to learn. When we looked at this proposal initially, there was not a lot of data, and there still is limited data on how these mRNA vaccines are going to affect infection. And I think that we're learning, just in the last week or so, that they're specifically to the South African strain and possibly the Brazilian strain, that there will be decreased efficacy with some of the mRNA vaccines. And so I think that will definitely play a role in what we're seeing, but also, what is currently prevalent in the community is what we expect that we will have present, whether it's somebody that we look at that has not been vaccinated or vaccinated. And I'd love to, in the future, if we're successful with this project, I'd love to be able to have control arms where we're looking at both that question that you pose in the future.
Great. And next question for you. So again, as a hospital epidemiologist, how do you envision that the results of this pilot study would potentially impact the future management that you would be involved in for the management of your employees at your institution or patients that you might be taking care of?
Yeah, I think that's also, going back to real life and what we've encountered throughout this pandemic. I think it depends on what we see. If there's certain bacteria or microbes that are present, is there something that we can do to help impact flora? Are there any screening methods that we would use in order to help know who is particularly at risk for vaccine failure? We've continued to be faced throughout this pandemic with supply chain issues with our vaccine. So are there people that we would prioritize for booster infections or booster vaccinations, depending on what we find in there. So I'm hoping that really, just opening up this box of understanding of what is in the microbiome and what gene expressions may have an impact on vaccine failure, that will lead to other interventions that we can implement in the future.
Great. All right. I'm going to borrow from the Q&A box to ask your next question, as we have a few minutes left, I believe. So the question from the chat is it is expected that variants, regardless of vaccination, are already or will become predominant, assuming in your community. How will you account for that for your study?
So we will be looking. We will be looking at what is present. We've collected samples since we started vaccination. So, there will be individuals that are closer to the January timeframe that that would have been considered immune after the vaccination. And then we'll also continuing to be looking at individuals up to, present day. So I think that, with our limitation of only being able to have a small amount of samples at this time, there will be some limitations, but really hoping that we can expand this work in the future and control for some of these issues that you do bring up that are very important about the variants that are circulating.
Great. And I'd also like to know a little bit more about your study team, particularly, who you're working with for the analysis of the specimens and who you're collaborating with.
Yeah, so I'm really excited about this team that I have because fortunately, Atrium Health has recently merged with Wake Forest, and this has allowed us the opportunity to really bring together a lot of great minds. So on the Atrium side, I have Dr. Passaretti, who's our Director of Infection Prevention and our hospital epidemiologist, who's been a great mentor. I also have Dr. Prim and Dr. Ahmed, Kristen Fisher, who helps with our data support, and Dr. Polk, who's another infectious disease physician, they've really been instrumental in helping me design this. And on the Wake Forest side, Dr. Laura Cox and Dr. Kimberly Reeves, who are both part of the Precision Medicine Institute at Wake Forest and have a lot of experience in looking into microbiome and molecular work. So I'm excited to bring these two individual teams together and hopefully get some interesting results.
Great. It looks like no more questions in the chat just yet, but I have one more for you. One of the challenges with performing sequencing, RNA sequencing for COVID-19 is having a swab with sufficient RNA or enough of viral material present to sequence the virus. Have you had any issues with these swabs or the specimens that you've collected where you've had inadequate samples, or how would you account for that in your analysis?
Yeah, that is a good question because, we've taken a lot of time to make sure that the specimens and to add to kind of one of your other questions of how we would expand this in the future too, we are attempting to bank most of to hopefully be able to look at, what was present in months prior compared to what's currently present in our population as well. But, definitely making sure that we are controlling by keeping them frozen at the -80 and as soon as possible, not refreezing, not splitting specimens has become important in making sure that we do control them. And then, also understanding that we may have some specimens that are unable to be analyzed. And in those situations, I think having ample backup people that we can include in our study population is going to be important too.
Great. Well, thank you very much for answering all of those questions. I think we're at time, so I think I'm going to pass it back to Erin.
Great. Thank you. Thanks so much, Matt. Nice job. Mindy, that was great. Very informative, very thorough. Thanks so much for doing it. Still sorry that we can't have people running across the big red balls on the Wipeout, but I'm still going to keep lobbying for that for next year to have this be an in-person reality TV show type thing. But for now, we'll keep going. So next, let's move on to the next contestant. And we have, the next contestant is going to be Dr. Shruti Gohil from UC Irvine, who is going to be interviewing John Baghdadi. And his presentation is, whoops, sorry, I got that. I think I have the wrong title here. Sorry, John, I have the wrong title here. Oh, it's Diagnostic Stewardship of Multiplex Molecular Panel Tests to Improve Antibiotic Use. So I'm going to turn it over to Shruti to take this one away. Thanks.
Okay, great. Welcome. Thank you, Erin, and welcome, Dr. Baghdadi. It was a pleasure to read through your well-written proposal. So before we start, maybe you can give us all a brief 2-minute summary for your proposal.
Absolutely. Thank you. Hey, I'm John Baghdadi. My mentor is Dan Morgan, and my project is based on the idea that diagnostic stewardship of multiplex molecular panel tests can improve antibiotic use in acute care. And so Many of you may have experience with these multiplex molecular panels, such as respiratory or GI panels. They are molecular tests that can evaluate your patient for up to 25 pathogens at once, including bacteria, viruses, and in some cases parasites. They have excellent performance characteristics, and they're very convenient to use, but for those reasons, they're probably overused. And we suspect or hypothesize that they're frequently used in clinical situations where they're unlikely to affect your patient's management. So the goal of this project is to apply diagnostic stewardship, which is a fancy term for more rational use of testing for infectious diseases, to improve their use in patient care and ultimately lead to better use of antibiotics. We're going to do it in 3 steps. In the first step, we'll do a survey of SHEA Research Network hospitals to see what strategies for diagnostic stewardship of these panel tests are already in place. In the second step, we will take those strategies from the SHEA Research Network, also pull some from the literature and refine them into diagnostic stewardship interventions based on feedback from clinicians. And then in the third step, we will do a pilot study where we implement 1 or 2 diagnostic stewardship interventions at 2 hospitals within the University of Maryland Medical System, and hopefully measure that they are able to change patients' outcomes and change antibiotic use. And the hope is that based on that pilot study, if the diagnostic stewardship interventions prove to be feasible, we can move on to a larger multi-center trial, which would be the first of its kind for this type of test.
Okay, great. Well, your first aim was going to be a survey SHEA Research Network investigators and solicit the perceived patterns of misuse, as you had mentioned, and overuse of multiplex panels for respiratory and GI pathogen. Can you just elaborate and give some examples of misuse and overuse that you have seen?
Yeah, absolutely. So this is actually one of the, I would say, toughest parts of this project is to define a harm from over-testing. I think in most cases, it's more of a soft harm in the sense that if you're evaluating a patient in acute care who has a cough and is likely suspected to have a viral illness, and then you diagnose them with, let's say, human metapneumovirus, that information doesn't necessarily have much to offer in terms of either prognosis or implications for treatment, implications for isolation. And so we suspect that when I say misuse of testing, really I mean low yield testing, testing where we can tell before the test is ordered that the information provided by testing is unlikely to be very helpful.
Yep, and related to that, you astutely mentioned that the results showing viral pathogens don't necessarily translate to a removal of antibiotics, but that bacterial pathogens invariably result in antibiotic use. How will your proposal attempt to address this important bias?
Sorry, can you help me one more time? The bias is that that when providers
that we tend to want to use. That we tend to want to use antibiotics if we get any bacterial pathogen out of there, but if there's a potential viral pathogen, it doesn't seem to result in a de-escalation of antibacterials. And will your proposal attempt to address this?
Yeah, so that's a good question. What you're referring to is there is a literature on this, that there's evidence that when confronted with a positive result for a viral pathogen, providers will be reluctant to stop antibiotics. We tend to say, well, what if there's an undiagnosed bacterial superinfection? Or, well, I'm still worried about my patient, or, well, maybe my patient is different than the patients in those studies. Whereas on the flip side, a positive test for a bacterial pathogen can be a strong stimulus to start antibiotics, regardless of whether the patient really has symptoms to warrant those. I think that this project is not necessarily geared towards understanding that aspect of clinical decision making. It's more about getting feedback from frontline clinicians about what is going to feel appropriate, feasible, and not too disruptive to their processes of care. And it's more about steering them or nudging them towards good decisions than really convincing them to stop antibiotics.
Okay, and I think this is related, so I'm going to go ahead and go a little bit out of order, but I know that there's a question in our chat that is asking about providing examples of diagnostic stewardship interventions that would maybe improve antibiotic use.
Yeah, absolutely. So diagnostic stewardship interventions tend to target the 3 categories of testing, sort of pre-testing or the decision-making around test ordering, then test processing, or in many cases, specimen processing, and then post-processing, which tends to be results reporting. So I think the most studies I've seen which provide evidence to show benefit really have to do with molecular testing for C. diff, where there's been quite a bit of work, quality improvement work related to diagnostic stewardship, where different medical centers have implemented either soft or hard stops before you place that order for a C. diff test, saying, does your patient really have diarrhea? And if they do, are they on a laxative that might otherwise explain their symptoms? And by discouraging testing up front, you then avoid unnecessary antibiotics down the line. In terms of respiratory pathogens, the truth is it's a little bit tougher to show how reducing testing can lead to less antibiotic use, in part because most respiratory panels are not going to be positive for a bacterial pathogen. But what we've observed, at least with, or what I've seen in the literature with GI panels, is that once these panels become available, because they're so easy to use, because they are so appealing in many ways, testing goes up. And once you submit a test, in many cases, you are put in a position where you have to maybe treat that patient differently. You may be more inclined to treat because you decided to test. Whereas before, when you needed to, let's say, order a sputum sample or maybe a stool sample, you would have said, we're just going to see what your symptoms do over the next day or two, and we'll make a decision about antibiotics later.
Okay, you touched upon my next question, so it's a natural transition. But as you mentioned, the pretest probability, it's absolutely crucial to the appropriate use of diagnostic testing, generally speaking. Will your project attempt to address this clinical considerations that go in to the minds of our clinicians that drive the test overuse or interpretation? It seems like there were opportunities both in AIM 1 and AIM 2 to address physician understanding and thinking on this topic.
Yeah, absolutely. I think right now I'm trying to stay broad so I can keep an open mind to comprehensive solutions that are going to attack testing at every phase. But there is a substantial literature about circumstances when we know that the pre-test probability of infection, or what I really should say is that the pre-test likelihood that the test is going to provide new or useful information is low. So for instance, repeat testing, there's a pretty solid literature both with respiratory and GI panels that if your patient had a respiratory molecular panel in the last week and you repeat it, it's very unlikely to provide new or different information than what you already have. And so I think being aware of those circumstances and having those as sort of options to target is certainly part of the game plan. But I really, at this point, want to be open to find out what SHEA Research Network hospitals are doing. And, you know, whatever clinicians respond the most positively to, that's what we're going to pick up and run with.
Okay, so your third aim is going to be piloting stewardship strategies. Can you describe your control hospitals? Are these largely community hospitals or academic centers? So
the pilot will take place at 2 hospitals within the University of Maryland Medical System, the main medical center, and then a much smaller second campus, the main medical center in downtown Baltimore. The plan was to use routinely collected data, metrics that are already being collected by system hospitals to minimize the requirement for chart review. The added benefit of that is that we can use other system hospitals as concurrent controls. Those are smaller medical centers, they're community medical centers. Some of them have teaching affiliations or residency programs, but it is true, I think, that the university medical center is in some ways different just because of its size and some of the services that it's able to provide.
Okay, and then your third aim also looks at, it looks to assess the feasibility of diagnostic stewardship strategy interventions, and the outcomes I noticed were largely clinical metrics. Which feasibility outcomes or metrics will you be considering?
So I think the main way that we'll be tracking feasibility, frankly, is by having discussions with stakeholders across the medical center to determine how these diagnostic stewardship interventions enter into their processes of clinical care, whether they're disruptive or whether they feel appropriate. You're right that the outcomes we describe, we look at mortality, hospital readmission, hospital onset C. difficile infection, antibiotic use metrics, hospital onset bacteremia. Those are more geared towards looking at safety and potentially helping us to generate an estimate of an effect size in terms of the impact of a potential intervention on antibiotic use. Feasibility is going to be more about a formative evaluation, and I didn't necessarily spell that out in the application because of the length restrictions.
Okay. Okay, we have some questions in the chat. What is the implication of C. difficile, of your work on C. difficile testing stewardship? Want to elaborate on that?
So I think the best literature for diagnostic stewardship is related to C. diff testing. And we're absolutely going to be pulling from that literature when we are trying to develop interventions, find interventions that are going to work for our clinicians, that are going to feel appropriate, feasible, and reasonable to implement. And I think it's also likely that that direction could go back the other way, where the interventions we develop and pilot could then be reverse applied to C. diff testing. The hope is that diagnostic stewardship interventions are not necessarily interchangeable, because each test is going to have its own applications, its own idiosyncrasies, but some of the concepts may be.
Okay, I don't see further questions in the chat. Maybe if we have just 2 more minutes, if I'm counting correctly, we'll ask one more question. Where do you see the clinical aspects of, actually, your question just popped up. I'm going to go ahead and take it because I know it's from Francesca, who's asking some really great questions here. More of a comment than a question she's mentioning. But to address the bias around positive viral and bacterial results in those patients who are tested with these panels, she's suggesting consider combining the panels with other diagnostic tests like procalcitonin to de-escalate or stop antibiotics. And in the few seconds that I read that, it actually ties into what I was thinking about, is that sort of the clinical, ultimately being able to tell that the clinical versus diagnostic aspects of the test and sensitivity and specificity related to that. I'm sure that that is out of the scope of the proposal that you're putting forward here. But that would be the future. Would that be the future plan for the larger study that you are planning to implement?
So let me see if I can respond to all of that. First, I probably am too enthusiastic or willing in this audience to admit that I'm a fan of procalcitonin. I think it probably has value in clinical care, though certainly implementation in different settings hasn't always necessarily worked out to achieve the goals that the investigators set out with. And so I think if we find in interacting with investigators at SHEA Research Network hospitals that pairing a molecular test with a procalcitonin gives providers that permission structure to not start antibiotics if there is an incidental positive, then that would be, I think, an intriguing intervention to try to develop further. In terms of sensitivity, specificity, and sort of some of the things you were mentioning, Dr. Gohil, in terms of the performance characteristics of the test, this is kind of a sticky subject for me, because I think in many ways the concept of a false positive result is really tough with molecular tests. These tests are so good that if it's positive, it's very likely that there are nucleic acids from the pathogen present in the specimen. But a different question is whether the pathogen that's present is causing illness, causing current symptoms, or necessitates treatment. And so I do think in a larger trial, there probably is room to explore some of those distinctions between a clinical false positive and a laboratory false positive, if that kind of gets at what you're asking me.
It absolutely does. It was actually, when I talk about sensitivity and specificity, I did mean to talk about clinical sensitivity and specificity. I feel that in the era of molecular diagnostics, I absolutely agree with you. Let me look to see if there are any other questions here. I think
I'm actually going to jump in because it's been 15 minutes. I know we get lots of great questions from both the audience and the panelists. So thanks so much. Thanks to you and also to Jonathan for really informative and thought-provoking questions. So we're now we've now gone through our first round. The plan had been for me to try to pull questions out of the chat and Q&A and use it for follow-up questions. Our panelists were so savvy with Zoom that they were able to do that during. So I think almost all of the Q&A questions were answered. If you felt like yours wasn't answered, please let us know. But I have a couple additional questions that I'm happy to kind of run through with the contestants just to wrap up here. So I'm going to change the order and start with Mindy, if that's okay. So one of the things you mentioned was about, you had a really good question about RNA and sample preservation, because I'm assuming that these are clinical samples. So I just wonder if you could expand on that a little more, because most clinical samples aren't stored to preserve RNA, like adding RNA later or something else that can actually preserve RNA. So I was just wondering if you've tried any transcriptomics that you talk about on these samples after they've kind of gone through freeze-thaw cycles, and have any like, what's your comfort that the data you're going to get is going to be valuable?
Yeah, so as you said, this was a really important question for us throughout, and we in the media that we are freezing our specimens in, we've worked a lot and done a lot of research with the molecular department to make sure that this will be possible. And we have some other projects that are ongoing as well that we will be doing this molecular work on prior to our analyzing our specific specimens for this project, in order to confirm that we'll be able to preserve or analyze the specimens despite them being frozen. But yes, they are clinical specimens.
So it sounds like you're working on that now, but don't have that kind of data yet to know if the samples are going to be adequate that you've already collected.
Correct. We haven't actually. Well, we've done some trial runs, but not on our specific ones that we would like to analyze for our project. The specimens that we're including in our data set.
Yeah, I mean, this is obviously we're fortunate in our field because we have access to so many specimens, but yeah, sometimes the limitations of that come up as well.
I think that one thing that we're going to try to make sure that we limit is that we, from the knowledge that we've looked into, we would like to not go past 6 months of frozen specimens, just from the way that ours have been preserved and frozen in the media that we're using.
Great. Another question is, COVID is changing so quickly. Mm-hmm. So, and you talk a lot about the variants, and you have some stored samples, and you plan to continue testing samples. I was wondering if you could speculate on, in a few months from now, I can't remember when the actual funding for this starts, mm-hmm. but say the funding comes through in 3, 4, 5 months. What do you think is going to be different at that time? And how do you think you may have to adapt to kind of changes in the pandemic to answer your question?
Yeah, so we have so many questions related to variants and vaccine and COVID. I feel like they're endless. So I think that, one other question that we are also, one of the you kind of led to that we're also trying to investigate is, other than post-vaccine infection, is also reinfections as well. So I think as we're continuing to try to answer this certain question, we're also going to be looking at reinfections in the future, what variables, whether it's microbiome or gene expression, or what we learn based on reinfections versus post-vaccine infections. I'm hoping that both of those questions will be something that we focus on in the upcoming months, and I predict that we will have to continue to look at in future work as we're learning about how many people have some sort of immunity, whether it's from natural infection versus vaccine related infection. or immunity.
Okay, I don't see any others yet. So I did set a timer for myself also, to be fair. I guess the final question is just for people out there that don't know much about transcriptomics. I was wondering if you could just tell people, like, how did you get involved in transcriptomics, and where do you see, or how do you see that playing a role in infection control or antibiotic resistance stewardship in the future? And you got 2 minutes for that one.
2 minutes, okay. Yeah, so I've learned a lot throughout COVID, and it's not something I was involved in pre-COVID or pre-working with Wake. And I originally got in the question of just, I want to know if this is a new variant or not, and trying to ask Wake, our Wake colleagues and how they could help us answer that. And it's really spiraled from there. So, what we are going to do is we're using the WGCNA network in order to help answer this question. So basically it uses, the approach is to filter a large sequence of data sets down to just a few groups of transcripts that are significantly correlated with a clinical trait, such as the SARS-CoV-2 strain, or a symptom severity, or whatever variable trait we decide to look at. Then we'll import these lists of correlated transcripts into the Ingenuity pathway analysis to help identify the role of these transcripts and what they're playing in the COVID infection. And then we'll compare those lists of correlated transcripts to the Coronavirus Network Explorer to help provide additional biologic context for infection. So I think that all of this sort of process that was really due to the mentorship I've had from some of the molecular scientists that have helped create it. And I think it's really interesting to look at this from an epidemiologic standpoint, whether we're just looking at microbiome. We've talked about that a lot tonight, but the work that they're doing, we've talked a lot about it for COVID, but I think there's so much potential there as well for other infections.
Great. Okay, sorry about the digging there. Thanks so much. Great discussion. And next, I'm going to move on to who did I have next here? Dr. Abbas. I think is she still with us?
Yes, I am.
Good. She kept. Okay, the coffee's still going. All right, great.
Yes.
The first question I want to ask you is, what do you predict is going to be the result of your study?
I predict that we will see a mortality benefit with this change that we are proposing to our guidelines.
And someone had asked earlier about, your sample size, and you talked about how you came up with your number of 150 based on the prior year, and how you could include the historic data to increase your sample size or extend the period. When you say that you think you're going to see a difference, were you able to do any power calculations to know within that sample size what power you have to see a certain difference, or what difference you might be looking for?
Yeah, so the numbers that I've projected are based on our patient volume. So I don't want to include or exclude anyone based on the sample size or the calculated sample size alone. I want to optimize this study in terms of its sample size. So whatever we can get within the 6 months preceding and proceeding the study approval period, all those patients will be included in our study. This is to optimize the sample size rather than limit it.
So were you able
to do a power analysis for this reason?
I'm sorry?
Not done a power analysis for this reason, to optimize the number of patients that we would include, because heme malignancy patients are already a small subset of cancer patients. And sorry, just to add one more thing, is that is also why I say that we need larger studies in future, which would include randomized control trials, for which we would do those power analyses to see, if it's statistically significant or not.
Yeah. Okay, great. Are you planning to do in your prospective period surveillance for colistin resistance?
Yes. So as I mentioned in my study procedure, that we will be, so the first step is to plate the rectal swab on a McConkey's agar, and with a meropenem disc. That would be the first step to identify if the organism is carbapenem resistant or not. And the second step is to identify the bug along with performing sensitivities. So that will automatically help us determine the sensitivities and colistin resistance.
So if I understand, that will be for the screening step when patients come into the hospital to determine to determine their empiric therapy. What about for people who've been in the hospital for a bit, who then grow a bacteria from a blood culture or from their clinical source? Or will there be any additional surveillance to see whether the increased use of colistin and meropenem is changing the microbiome of the hospital and increasing overall colistin resistance?
Got it. Yeah, so we generate antibiograms annually, and we actually keep a very close eye on that. So we actually do that as a routine thing in our hospital. So that is definitely something we'll be keeping an eye on.
Got it. So you guys are doing routines screening for colistin susceptibility.
Yes.
Great. Tell me, there was one other question in the chat here. Mark Shelley asked, how will you consider or adjust for changes in behavior as caregivers become aware that patients have SHEA recolonization? Aside from your empiric antibiotic use, how will you kind of adapt to that information?
Yeah, so Erin, I'm just going to repeat something that I said in my intro, is that when I moved back from the US, this was actually the cultural change for me, was seeing a completely contrasting epidemiology here. Just to put things into context, I was looking at a study from last year that was conducted in the US, conducted in 49 hospitals across the country, where including infections and colonization, the CRE incidence was about 57 per 100,000 admissions. And now if I look at the data for my own hospital, and this is not including colonization, this is only including infections that are either bacteremias or urinary tract infections or wound infections or pneumonias. And the incidence is about 3,007 per 100,000 admissions. So it's about 50 times higher. So actually, and I'm not just being overly optimistic, I'm being very realistic, is that we see these infections so commonly that I do not anticipate a major behavioral change, because this is really what we see all the time in our hospital. What I do anticipate is that we will be introducing contact precautions, which would not have been in place otherwise. So that will introduce the shortcomings in clinical care that are introduced by institution of contact precautions. For example, and studies have shown that physicians or anyone who enters the room might spend their visits to patients' rooms might be brief compared to those who are not on contact precautions, so on and so forth. So those are the things that I'm anticipating.
Great. Well, thank you very much. We appreciate your overview and your thoughtful responses to questions. Now I'm going to move on to John. He's our final panelist, our final contestant. Sorry, I'm starting my timer to keep myself honest here. So your first aim that uses the SHEA Research Network, if I remember, you're doing that to try to understand kind of attitudes and beliefs around the use of these rapid diagnostics in sites. The SHEA Research Network targets one individual at each hospital. So I was wondering if you want to comment on the generalizability of that approach to assess kind of attitudes and beliefs around the use of these tests across different sites.
Sure. The truth is, I think that's probably a limitation of each one of my aims is issues with generalizability. But the goal of the project is not necessarily to glean universal truths about the way these tests are perceived or even how they're used. It's really more about identifying, developing, and then pilot testing interventions, which could be more effective or effective at other medical centers besides where we pilot them. And so I think the SHEA Research Network is a tremendous resource, and having access to more than 100 high-level research institutions and be able to sort of pick the brains of the individuals who are operating there and running studies is an asset, which made sort of applying for this competition appealing to me. Those people who respond to our survey don't necessarily need to reflect sort of every perspective on testing, but if they're able to give us a few good ideas that we can then sort of develop more, spend time with, and then pilot test, I think it'll have been worthwhile.
Great. My second question is, you talked, maybe I missed this in your proposal, but you mentioned earlier some of your outcomes. You talked about hospital-onset bacteremia, mortality. I don't remember you talking about antibiotic use. I don't remember you talking about test use. Are you going to be measuring the rate of, I assume, but I didn't say the rate of tests, like how often is there a reduction in the number of these platforms being used?
Yeah, that's a really good question. So I think this also gets kind of to the question that Dr. Gohil asked me earlier, which is really talking about outcomes that address the fidelity of an intervention, or maybe get more closely at feasibility. And so certainly if the intervention that we pilot is designed to discourage testing or limit testing, then tracking test use over time would be an important process measure, which could help us understand why or potentially why not the intervention was effective. But if the intervention is geared towards flavor text that would accompany test results, for instance, we did not identify a bacterial pathogen which would benefit from antibiotic treatment, then reducing the amount of testing would not necessarily be an appropriate outcome. So I think we are going to incorporate outcome process measures, but they're going to be geared towards what the intervention is designed to do. And also the truth is, my expectation is that testing is only going to become more widespread. I think I saw this comment in the Q&A about suspicion for COVID and how that can drive respiratory panel testing. At the medical center, we saw, so COVID only got added to our respiratory panel in the fall, so about 1/4 of the year, and yet we saw a increase in the number of tests by, I think, 1,500 or nearly 2,000 from 2019 to 2020. And so looking at just the raw number of tests, I think it would be potentially a problematic outcome, because my expectation at baseline is that it's just going to increase year on year.
Great. So I thank you for answering that question about impact of COVID, because that was my next one. So if I heard you right when you talked about measuring testing, it sounds like you're distinguishing, looking at a reduction, but maybe you could comment on measuring appropriateness, because it might be that testing should go up as opposed to down. And have you thought about how you could measure appropriateness of testing?
Yeah, I think my answer to that question is that it seems like it would be really hard. Studies that have tried to address the appropriateness of antibiotic use tend to involve chart review and potentially review by multiple experts who would then need to agree that antibiotics were either appropriate or inappropriate in a certain situation. And that's in a research setting where there are pretty detailed guidelines about when you're supposed to use antibiotics and what types of antibiotics you're supposed to use. So I think that would be really tricky to measure the appropriateness of diagnostic testing, which is why why at least I envision this project focusing more on downstream outcomes. For instance, was there a change in clinical management based on the test results? Did we see a change in patient's length of stay? Did we see a difference in antibiotics? Were antibiotics stopped? It's hard to determine whether it was right to test or not, because each patient is different. But if overall at an average population level, you can see that testing is, or we're able to increase testing in situations where it, for instance, shortens antibiotic length duration, then that would suggest that testing in those situations was a good idea.
Great. All right. Well, thanks, John. I want to thank all of our contestants, all of our panelists. our secret judges, Tony, Sue, and Rebecca, and to all of those who joined tonight. Our panel of judges will now be processing the night and submitting their scores within the next week. And next week, we'll convene at the SHEA Spring Foundation event to announce the winner of the competition. We hope you can join us then. Again, thanks for joining us. Thanks to all the participants, and have a great evening.